Okay, I'll start the recording. Welcome. And I think the first case we will do is a case that you shared with me of a 50-ish-year-old woman with a tumor or mass in the renal hilum. And so here we see this mass, and it looks as though we have some kidney parenchyma here, tubules there, and then a little bit of smooth muscle forming a boundary here that probably represents the renal pelvis and beginnings of the ureter, I suppose. So it looks like it's within the renal environment. Morphologically, this is smooth muscle. And then we have what looks like a very mucinous neoplasm with cystic spaces and a few goblet cell-like structures. So it has a sort of a intestinal morphology almost. What was the presentation on this case, Dr. Lin? Did it present with renal failure or obstruction? How did we discover that this was present? I think you may have mentioned something about stones. So one thing that I notice about this tissue is that the glands are quite orderly. Some are large. Yes, welcome, Dr. Tom. Some are large glands, but many of them have a very bland or non-proliferative appearance. A few are wrinkled and so forth. So to me, this looked very much like the possibility that this was a very low-grade neoplasm. There's not much nuclear atypia. There's not disorganized single-cell infiltration. It's generally large glands and large cystic spaces with relatively low grade. Now, that doesn't mean it's totally benign. We have one more slide, I think, that you sent here showing, again, this picture with muscular type tissue bounding the neoplasm. And, everywhere seems to be fairly defined. So I can see how that would be difficult for urine to pass through this, but I don't see features of a high-grade aggressive neoplasia in this lesion architecturally. Now, you had sent us some immunohistochemical stains as well, but if I were to say one thing that this looks like, it would be of some of the low-grade mucinous neoplasms that we see in the GI tract and in the ovary. This was a woman, and interestingly, there have been reports of retroperitoneal and perinephric masses that very much resemble mucinous cystadenomas and mucinous neoplasms of the ovary. So I think this sort of, to me, made that thought come to mind. Could this be one of these neoplasms of renal or mesonephric type origin that can be found along the mesonephron embryologic pathway. So let's take a look at the immunostains that we sent. Here's the CDX2, and we had several positive cells, but not everything. So kind of much like what you see in the ovary. And I think this also is very helpful because it helps to exclude the possibility of a colorectal metastasis. Now, of course, this still could be from a site like the appendix or maybe upper GI tract. Certainly, there are some pancreatic neoplasms that can have this type of positivity. And let's see, I believe you told me there were some other positive stains as well. Dr. Lin, do you want to comment on that possibility, on the other staining results?
Yes. Professor, all marker is negative. For example, SAP2 negative, SAP22 negative, and the TPM1 negative, PHS negative, and VATN3 negative, RTC negative, and YT1 negative.
Yeah, so negative for all of those markers. I don't know. I don't recall that you did CK7. I would expect that it would probably be CK7 positive.
Yeah.
Oh, it's negative? Yeah, okay. So yeah, this certainly falls into the category of these mucinous neoplasms of the retroperitoneum, ovary, that can have this sort of enteric appearance. And the behavior, yes, there they are, the GATA3, RCC, WT1. Oh, CK7 was positive. Yeah, so these are a CK7 positive mucinous neoplasm with little weak CDX2. So that fits into that category of the mucinous neoplasms, and very much like what we would see in the ovary with borderline mucinous tumors or mucinous carcinomas. In terms of how to classify this, would we call it a borderline tumor? Would we call it a carcinoma? I think given what looks like the well-circumscribed and defined nature of it, I don't think this has a high propensity to invade as long as it has not directly spread or ruptured in some location. But I think the metastatic potential to lungs or liver or any place else would be very low. Now, what you might see on occasion would be synchronous or involvement of the ovary, because it certainly embryologically is probably connected to that site. And so watching the ovaries would be valuable in this case as well. But I think I would probably term this a mucinous neoplasm rather than calling it a mucinous carcinoma, because I don't think it has the same potential, and you would be very possibly prone to have it be overtreated. Most likely, as long as everything else is clear, if this has been resected with the kidney, that's all that's going to be required in this patient. So I think this is a very interesting case. I've seen a couple of other cases like this over my career. It's quite rare to see it in the retroperitoneum, but it does happen there. I remember the first one I saw, I asked my professor, Dr. Scully, who was a very well-known GYN pathologist, about these cases, and he said, yes, this happens in the retroperitoneum, and they look very similar to the ovarian lesions. Any questions or comments about that, Dr. Dom or Dr. Chom? Well, I have a very interesting case I thought we would spend a little bit of time discussing as well. So let me share that with you. This is a patient from our clinics who has been followed by the liver doctors, the hepatologists, and was being followed with the thought that he was developing cirrhosis. And he had some elevated enzymes, and the attending internal medicine doctor, who's very, very bright, was still thinking that this would be cirrhosis and that he should have the patient biopsied to fully confirm that and to see if we could get any sort of etiology. I think the patient had a history of hepatitis C, and that was part of why he thought he may have cirrhosis and would need to be followed. Well, here you can see the biopsy fragments. In this case, the fragments are sort of falling apart. Whoops, how did that happen here? Just got kicked off the site. Okay, let's see if we can find the case again. Hope this is the right one. Yes, oh, we got lucky. So as you can see, there's tumor here, there's tissue here, but it does not look like liver tissue. It has a lot of blood associated with it. You know, some of it may be partially clotted and so forth, but it's a very cellular tumor and so forth. But here at higher magnification, I think you can see that these nuclei are fairly bland. They're sort of epithelioid to maybe slightly spindled. And we have a lot of these little round microlumina or microcystic spaces in the tissue. So I don't, if you want to jot down in the chat what you think this might be, I would be interested in your thoughts about what kind of a tumor this might be. It's clearly not cirrhosis. So that's kind of where we were, not helped particularly by the clinical history or the clinician's workup, and dealing with a neoplasm, a lot of red cells, a lot of sort of vacuole type spaces and so forth. What could this be? Well, of course, we had the advantage of being able to do some immunoperoxidase stains. And the first one I decided to go to was this stain. Let's see if we can. Yeah, I can't show you what the stain is because that would show you the name. But this is CD34. So this tells us that we're dealing with a tumor which makes some degree of vasculature. And many of these small microlumina are staining positively, and a little bit of staining in the background. So a vascular neoplasm. Any ideas of which vascular neoplasm this would be? We had a case of angiosarcoma of the liver, about 9 months ago, and typically angiosarcoma in the liver is a very high-grade neoplasm. This, in contrast, is more low-grade, and to kind of further illustrate that, I'll show you some of the other stains here. So this is the cytokeratin stain, CK7, and I think you can see that there's really no positivity, although there is a trace, maybe a little bit in a few of these cells, a little bit of granularity here and there. This can be quite variable in these tumors. And then here is your Ki67 stain, which gives you a nice impression of the degree of proliferation that's going on. So it's certainly not negligible, but it's also not high grade. So frank angiosarcoma of the liver is usually a very high grade and pleomorphic neoplasm, and would be expected to have a much higher Ki67 labeling index. So the other stain we have here, I think this is the control. Oh yeah, this is our control. There you can see the Ki67 in a lymph node is staining that way. So with this information, a vascular neoplasm, kind of low to intermediate grade, somewhat epithelioid appearance, we made the diagnosis of epithelioid hemangioendothelioma. And as you know, this is a very unique and interesting neoplastic process because it can occur in multiple sites at the same time that are not particularly related, such as the skin, the liver, the bone, and it's not necessarily metastatic tumor. It seems like it's more likely a how would we say it, a sort of field effect type of lesion. Now, could this be Kaposi sarcoma? Well, I suppose that's in the differential, but it really doesn't fit the appearance of the Kaposiform sarcomas or the Kaposi sarcoma. And liver is a relatively uncommon place for that to occur as well. Certainly would be very uncommon for it to be the presenting site, and would not have this kind of occult presentation masquerading as cirrhosis for a period of time. Well, let's go on to a different case for kind of fun's sake. And we'll pick up another case that came in our tumor board recently. Find that. There we go. So this is a fairly typical pancreatic resection specimen. And this patient had neoadjuvant therapy. Now, this is not the best slide, so let's see if we've got a better slide here. So the patient had had a neoadjuvant therapy, and after neoadjuvant treatment, they thought, could we get a good resection? And it looked as though they'd had some regression, shrinkage of the tumor, so they opted to take the patient to the OR to do a Whipple procedure. And with that procedure, typically they will perform frozen section on the margins. And that can be challenging in a neoadjuvant setting. So we typically freeze, the close margins, which can include the uncinate process margin, the retroperitoneal margin, if you will. And we typically ink that black with black ink, which you can see on the surface here. And it comes through nicely for frozen section. As you can see, we have some tumor here fairly close to the black ink. This is the tumor there. And this is one of the sections that was performed with frozen section. I'll give you another example here. We'll go to this case over here. This is another of the frozen section slides. And as you can see here, again, we're very close to this inked margin. We don't have tumor right on ink, but we do get several sites where tumor is very close to ink. Now, what happened with this case was that the initial frozen section was reported as positive, and that was this first slide that I showed you here, which is kind of blurry. Not the best frozen section. So here we had reaction to the surgery with fibrin and tumor right here. So this was reported as positive. And so then they went back and resected more tissue as the superior mesenteric artery tissue and provided this additional tissue, which again showed tumor quite close to the margin. So with neoadjuvant treatment for pancreatic cancer, it can be very difficult to get good clear margins. And here you can see one of the other the reason why we submit lots of blocks for frozen section is to identify sites like this and hopefully get a clear margin. But here on the frozen section, you could see cautery coming down to and involving areas of tumor, involving this perineural area here. And we also could see that we had tumor invading into this lymph node here. So here's a lymph node containing tumor and quite a bit of tumor. Even though it's come through direct invasion, that still is, of course, staged as a lymph node metastasis. So let's see if we can find our other case here. And maybe I'll just, well, maybe we'll just pick a couple of additional slides from our recent cases. I've marked these as interesting cases, and so we will presume that there's something to be learned from them. So another area where I see a lot of cases is in the evaluation of Barrett's esophagus. In the United States, the incidence of esophageal adenocarcinoma is increasing. And to be quite frank, I suspect the same will or is happening perhaps at a lower rate in Vietnam now. And so since the incidence of adenocarcinoma is related to the development of Barrett's esophagus with dysplasia, we oftentimes will have people who have Barrett's esophagus identified followed regularly to evaluate for dysplasia. And of course, there it depends on the length of the metaplastic segment that they have and how much that is involved, that will determine whether or not it becomes of great concern. If they identify dysplasia, particularly any suspicion of high-grade dysplasia, or they see any degree of nodularity in the mucosa, they will then do an endoscopic mucosal resection, where they will inject saline into the or some other fluid into the submucosal tissues to raise up an area of tissue that they can then capture with a loop and excise as a single fragment. That allows us to get good evaluation to see any degree of invasion or not. Now, sometimes what happens is that they see other things that they think may be neoplastic. So, for example, submucosal esophageal glands like this will sometimes be large enough that they're visible as a little bump in the esophagus. And so those areas tend to be resected in somebody who has Barrett's esophagus. So in this particular case, we don't see any excess tissue here, but you see I've highlighted an area here. Let's go down to there and take a look, because I think right here we have the beginnings of low-grade dysplasia. So here's a fairly normal, if you will, intestinal metaplasia. And then beginning right here, we have an area with increased stratification, a little bit of loss of cytoplasmic mucin and demarcation lines. And we also see that the nuclei begin to have a few nucleoli. You can see those here. So this little small area, I would deem as a small area of low-grade dysplasia. It's at the surface, which is one of the criteria that we use for detecting dysplasia in these patients. And it's more than just a single gland. It goes clear over to here, maybe even a little bit farther. And we don't have any active inflammation. But here you can again see increased size of the nuclei, the beginnings of nucleoli, a little bit of loss of polarity, but certainly increased size compared to a more normal metaplastic gland here next to it. We'll look at a couple of the other sections as well. Now, again, in these endoscopic mucosal resections, we put ink on the deep margin so that we can determine true margins if there's invasive neoplasia. Here you see these submucosal mucin glands, which are likely the reason for resection. And of course, there will usually be somewhere a duct that is coming to those submucosal glands. Sometimes this duct can be lined by squamous or slightly stratified squamo-columnar mucosa and is not neoplastic. What we can also see, however, in this particular case, is you can see that here there is an evident mass lesion. The mucosa is busier up here, and then we have this beginning of an indentation into the lamina propria. In the esophagus, in many patients, we have what's called the reduplicated muscularis mucosa. So we have a few strands up here of smooth muscle that are part of the muscularis mucosa, and sometimes people will think that that's the muscularis mucosa, and so if we just have a superficial biopsy and we see this tumor here extending below the this smooth muscle, we might think that this has become a more serious tumor, maybe what we would call a T1B stage, and therefore potential for metastasis to lymph nodes. But in reality, what happens in the esophagus is that the true muscularis mucosa is sort of spread or duplicated with a superficial portion and then the true or deeper muscularis mucosa down here. And that is, it's helpful to recognize that the reason that the T1B lesions are a greater risk for metastasis is because here they have access to the larger vessels, lymphatics, and so forth that are down in this submucosal space. And that's where you'll see these glands and larger vessels. In contrast, up here, we see only very thin-walled vessels. We see the ducts, but not the submucosal glands. So what else can we learn from this resection? Well, there are many patterns that esophageal adenocarcinomas can take. And this is one of the less common ones. This is kind of a small glandular form of this tumor. And it's fairly poorly differentiated. It's got some very irregular architecture and so forth. More typically, we see an intestinal type of malignancy with larger glands and so forth, but sometimes even in those cases where you have high-grade dysplasia in the mucosa with intestinal type glands, you'll see small glands trickling off the base of those as invasive carcinoma. If my biopsy was just an area like this, I would not call this high-grade dysplasia. I would call this intramucosal carcinoma because the glands are confluent, the architecture is disturbed, and we also see the nuclei rounding up with nucleoli and a degree of pleomorphism. So that would be intramucosal carcinoma. This over here obviously tells us we have superficially invasive carcinoma. Similarly, over here, we can kind of see things back to back. So here we have more generic intestinal type dysplasia. It's changed the surface here, and you've got abnormal architecture. You've got some stratification and some nuclear enlargement. This would still be low-grade kind of dysplasia here. Maybe there's a few glands like this where the nuclei are starting to round up a little bit. It's becoming more solid. So this might be turning towards high-grade dysplasia. But then right here next door, we see abnormal architecture. The glands are closely packed. This would be best termed intramucosal carcinoma. And in fact, here you see these, again, glands sort of drifting downwards, probably below the smooth muscle here as the beginnings of invasion. So this is quite instructive. Let's take a look here. I've got one more teaching spot over here to highlight. By now, you'll probably be able to look at this and go, oh, this is low-grade dysplasia. And that right next door to it here, we have intramucosal carcinoma and actually an area of superficial invasion. Now, one of the nice things about digital pathology or digital slides is that you can measure things. So, for example, I was able to measure the full depth of the invasion. I was able to measure the distance from the margin, the cauterized margin, and the overall width of the lesion here in its greatest dimension. So you can get some nice, accurate measurements with digital pathology as well. We haven't gotten to the point where this level of accuracy and measurement has much prognostic value, but perhaps as the digital pathology becomes more prevalent, we'll see that sort of change happen. Any questions about Barrett's esophagus and esophageal adenocarcinoma? I'll just let you know that one of my trainees is preparing a very nice teaching module for Barrett's esophagus that we hope will be a great training tool for programs virtually anywhere to use in training people with on how to make the diagnosis of dysplasia in Barrett's esophagus. Because as I said, I think this is going to become a more frequent issue for you in the future. All right, let's take a look at this case. I flagged this case for some reason. Let's see what's here. Well, this is obviously all neoplasm. It's all very homogeneous. Let's see if I can recall where this came from. Okay, yes, now I remember. So this is a patient who has a GI stromal tumor, has had the GI stromal tumor for some period of time. And the patient has been treated with Gleevec or the c-Kit inhibitors, the tyrosine kinase inhibitors, but now has developed masses in the abdominal wall and mesentery. And so this is essentially a recurrent or post-neoadjuvant treatment GI stromal tumor. As you can see, there's really not much in the way of necrosis. We can look at one of the other sections on this tumor. Here you see more spindle cell variety in areas, but even here we don't see much of any treatment response except for this slight myxoid change in areas. So I think this could sometimes throw us off. If we got a tumor like this that had this sort of biphasic myxoid and solid areas, we might, and it was just listed as a soft tissue tumor, we might be considering things like synovial sarcoma, or we might be thinking about things like, maybe a myxoid leiomyosarcoma or something of that sort, or maybe if it was a woman, an endometrial stromal sarcoma of high grade. But this is just the appearance of a post-treatment non-responding GI stromal tumor. This is certainly one instance where when they cease to respond, this is the time when we oftentimes will turn to do molecular genetic analysis to see if we can identify other potential treatable targets. So we might do the gene assays looking for potential drug targets, mutations in these patients, the kind of things that Gene Solutions in Ho Chi Minh City is doing, or Foundation One Medicine, and so forth. You're very fortunate that Gene Solutions is very low cost relative to what it is in the United States. And of course, now they are a fully accredited CAP laboratory, CAP accredited laboratory. So certainly working with high quality and good procedures and so forth. So that's a nice example of what a treated GI stromal tumor can look like. You'll notice I didn't do any immunohistochemical stains on this case because this was essentially a debulking to get tumor for that molecular analysis. So we did routine histology, but because the morphology was consistent, because previously we'd worked it up very thoroughly. Doing additional immunohistochemical stains for diagnostic reasons would not be particularly helpful at this stage of the patient's evaluation. All right, let's see if we can find another great case here in my bookmarked files. Okay, so here's some GI biopsies. This is a 19-year-old female. And we have what looks like some ulcer or tumor. Very inflamed tissue with inflammatory exudate. This is one of the situations where I often find that the new trainees have difficulty is that they see a tissue like this from a gastric biopsy. And that's actually, I think, the reason I flagged it is because in reviewing this case with my resident, they were convinced that this was carcinoma. Well, a couple of things would make you think twice about that. One is the age of the patient, certainly at 19, does not look likely to be related to carcinoma. Secondly, we see here we've got lots of plasma cells, some eosinophils. And so the plasma cells are certainly not malignant. And these other rounded structures sometimes can look like glands, but are actually very nice endothelial-lined structures, the granulation tissue type vessels. So why does she have a very dense lymphoplasmacytic infiltration? And then she has this, very exuberant sort of foveolar cell hyperplasia going on. In addition, even maybe this is, well, I wonder if this may be rectal. Yeah, because we've got goblet cells here, so this may be rectal. So this could be a rectal lesion. And in that situation, with an inflammatory type polyp and ulcer and so forth, we would want to be thinking about things like rectal prolapse syndrome or inflammatory polyps due to other causes. Let's see what else we've got on this patient here just for discussion. She could have had inflammatory bowel disease also, I suppose. And here we see, I think, a non-inflamed section of bowel, but you can see there's some glandular distortion, variability in spacing, and some branching of the crypts. This is not normal. When you see branching of the crypts, it means there's been some damage to the mucosa, and very often they're shortened. If I'm recalling correctly, I believe this patient did have Crohn's disease and had not been very compliant on their evaluation. So here's her duodenum. This was spared, and then what else did we get here? Here's her stomach, and I think this was spared. So we had rectum, colon, and so forth. Now, sometimes in the gastric mucosa, you can see features that suggest Crohn's disease. There usually will be, at the very least, a significant increase in eosinophils. This is not a significant increase. This is an increase. I think normally the gastric mucosa would have one or no eosinophils, but here in this small field, we've got 3 or 4. which is, not a huge number. It's not eosinophilic gastroenteritis, but it's certainly moving up towards an inflamed gastroenteritis. So that's 4 cases, 3 or 4 cases of different varieties from my day-to-day practice and some of my thoughts about them. I appreciate the chance to share them with you. We're pretty much at the end of the hour. So I'll stop and let you ask any questions that you may want to ask. Everyone has gone to sleep or gone to work.
I want to ask you about my case tumor in kidney. Do you think about the mucinous neoblast in from ovarian?
Yes, if I were looking at that case, I would let me put in the chat what I would say. I would say
Why it's not primary in kidney
no, I think this is primary tumor of the kidney.
yeah.
Because this type of tumor can occur in the kidney, in the urothelial tract, or in the retroperitoneum. I think it's related to the mesonephric type of, or not the mesonephrin, the Wolffian ducts and so forth, that as those are related to development. We don't know for sure. I mean, it doesn't have the marker of PAX8 that you'd see with the mesonephron, but we don't see PAX8 in the mucinous tumors of the ovary. We don't see, very much of that. So it's a metaplastic, neoplastic process that we can see in this anatomic location. But I do believe that this is a primary tumor of the kidney, ureter. Actually, let's take a look and see what we've got on the CAP checklists for the ureter. And okay, let me share my screen again here, and we'll just look down that checklist. So this is the CAP protocol for patients with ureter and renal pelvis. And as we look at histologic types, this is not a urothelial tumor. It's a glandular tumor. At most, it's adenocarcinoma in situ, because I don't think we have invasive tumor in this lesion. But that's why I said at least borderline. I mean, it could be an in situ neoplasm. We don't have a borderline category that's recognized in this location. I suppose you could call it an enteric type of adenocarcinoma. But again, I think this is in situ. I don't think it has invaded into hasn't invaded into the muscle. If you have invasion of the renal parenchyma, then I'd probably call it enteric adenocarcinoma invasive of the kidney. We did have that one area where it looked like it was adjacent to the nephron, the renal papillae, so it could be invading into the kidney itself. But this is where I think it fits, is under glandular tumors. Now there is, let's look at note B here. Each of these cancer protocols includes some very helpful notes. So this is the note about histologic type. And that includes this enteric type of adenocarcinoma. So that's probably, I think, where it belongs. Now we call it enteric type, even though it doesn't have CK20. It has the goblet cells, it has patchy CDX2, and it doesn't have other things. Well, very good. It's time for you to go on with your work day and get some work done. Time for me to go to bed, sleep before I go to work tomorrow. It's good to be with you. And thank you all for your interest and continuing efforts to serve your patients.
Yeah, thank you very much. Have a good night.
All right. Bye.
Goodbye.